Hello everyone. Today we are going to explore amputations from a musculoskeletal physiotherapy perspective, focusing on biomechanics, rehabilitation, and functional restoration. Amputation is not just the loss of a limb, it represents a complex neuromusculoskeletal and psychosocial condition that affects movement, balance, energy expenditure, body image, and quality of life. As physiotherapists, our role is to guide patients through pre-operative, post-operative, and long-term rehabilitation with the aim of restoring functional independence and participation. So, what is the definition and types of amputation? Amputation refers to the surgical or traumatic removal of a limb or part of a limb. Common levels of amputation: upper limb, transradial, transhumeral, shoulder disarticulation; lower limb, transtibial, below knee; transfemoral, above knee; knee disarticulation; hip disarticulation. Clinical significance: the level of amputation significantly influences functional outcomes. For example, transtibial amputation generally have better mobility and lower energy cost. Transfemoral amputations require greater energy expenditure and complex prosthetic control. Indications for amputation: amputations are performed due to peripheral vascular disease, most common, diabetes related complications, trauma, malignancy, severe infection. Each cause has implications for healing, rehabilitation potential, and prognosis. Biomechanical and physiological implications: amputations result in significant changes in center of mass, muscle imbalance, energy expenditure, gait deviations. So, first one, center of mass. Loss of limb mass shift the center of gravity, affecting balance and postural control. Muscle imbalance. Muscle groups are disrupted, leading to weakness, altered force generation, compensatory movement patterns. So next one, energy expenditure. Energy cost of walking increases 10 to 40% in transtibial amputations, up to 60 to 100% in transfemoral amputations. Gait deviations. Common deviations include circumflexion, hip hiking, vaulting, lateral trunk lean. These compensations occurs due to prosthetic limitation, muscle weakness, balance deficits. Post-amputation complication: phantom limb pain, residual limb pain, contractures, skin issues. So first one, phantom limb pain. Patients may experience burning, stabbing, cramping sensations. This is due to central and peripheral neural mechanisms, including cortical reorganization. Residual limb pain caused by poor prosthetic fit, neuroma formation, infection. Contractures. Common patterns: hip flexion contracture, transfemoral; knee flexion contracture, transtibial. These can significantly affect prosthetic use. Skin issues includes pressure ulcers, skin breakdown, friction injuries. Physiotherapy management across phases. Phase 1, preoperative rehabilitation if planned. Goals included patient education, strengthening cardiovascular conditioning, psychological preparation. Early preparation improves post-operative outcomes. Phase 2, acute post-operative phase. Goals: protect surgical site, reduce pain and swelling, prevent complications. Interventions: positioning, prevent contractures, avoid prolonged hip flexion, encourage prone lying if appropriate. Residual limb care includes wound care, edema control, shaping of the stump. Early mobility, bed mobility, transfers, wheelchair training. Phase 3, pre-prosthetic rehabilitation. This phase is critical for prosthetic readiness. Goals: improve strength, enhance balance, prepare for prosthetic fitting. Key components: strengthening, focus on hip extensors, abductors, core stability. Balance training include sitting balance, single leg standing if safe. Desensitization helps reduce sensitivity of the residual limb. Phase 4, prosthetic rehabilitation. Prosthetic training includes gait training, focus on weight transfer, symmetry, step length. Functional training includes walking on different surfaces, stairs, community mobility. Energy efficiency, teaching patients to reduce compensatory movements, optimize gait mechanics. Clinical reasoning in amputee rehabilitation. Physiotherapy management must be individualized. Considerations include level of amputation, cause of amputation, comorbidities, age and functional goals, prosthetic components. Example: a patient with transfemoral amputation due to diabetes may present with reduced cardiovascular fitness, poor wound healing, balance deficits. Management should include gradual conditioning, careful monitoring of skin, progressive gait training. Outcome measures. Physiotherapists should use objective measures such as timed up and go, like tuck test, and 6-minute walk test, amputee mobility predictor, AMP. These tools help evaluate functional progress and rehabilitation outcomes. Key clinical takeaways. Amputation is a multi-dimensional condition requiring biomechanical understanding, structured rehabilitation, patient-centered care. Physiotherapists play a central role in restoring mobility, improving independence, enhancing quality of life. Amputation rehabilitation is not just about restoring walking, it's about restoring function, confidence, and participation in life. Through structured physiotherapy and evidence based practice, we can help individuals achieve meaningful recovery and independence. Thank you for joining this advanced discussion on amputation in musculoskeletal physiotherapy. I'll see you in the next video.